There is a growing push by doctors and public health experts to correct the record and to spread the message that if you think you're allergic to penicillin, there's a good chance you aren't. About 10% of people think they have a penicillin allergy, but when they're actually tested, far fewer had a true allergic reaction. So what is the real number? And what are the consequences of avoiding that drug? Dr. Chistopher Labos is with us this morning, epidemiologist and cardiologist, and the author of the book, Does Coffee Cause Cancer? And 8 more myths about the food we eat. He's in Montreal this morning. Hi, Dr. Labos.
Hello, Heather.
So that 10% figure, that is the CDC number for U.S. numbers, but it's commonly accepted in Canada as well. So sort of a North American number, that 10% think they are allergic to penicillin. How many actually are?
Far fewer. If you actually formally test people for a penicillin allergy, about 90% of those people that you test are not going to have a penicillin allergy. So we think that the prevalence of penicillin allergy is about 10%. That's the commonly quoted figure, as you said. The reality is closer to 1%. So the vast majority of people who think they're allergic to penicillin really aren't.
So why do they think they are?
Well, they were probably told that they were allergic to penicillin as a child, and that sort of label has followed them throughout their life. It may be that they got sick as a result of the antibiotic but didn't have a true allergy. It could be that they just had a rash, which may have been related to the antibiotic, but maybe not. Or it could be that, they had a family member that was allergic to penicillin and their parents didn't want to take the risk and said, well, all my kids are allergic to penicillin, let's give them something else. So sometimes just this sort of offhand comment can follow somebody throughout their entire life. And the problem with the medical records is that a lot of stuff gets copy and pasted over and over again. So something written somewhere at some point in time could still be in your medical record 20, 30 years later because nobody has bothered to go back and correct it.
Or maybe more. I mean, we were doing an informal survey, anecdotal, here on our morning team, and easily 3 members of our team, myself included, fall into this group. And here's my own story. I was always told that when I was a toddler, I had some sort of reaction, hives, I believe, but a severe sort of skin and redness reaction. And so I've had medical alert bracelets over my life and believe to this point that I'm allergic to penicillin. So I'm sort of exactly what you're talking about.
That is the classic story, right? I mean, often something that happened when somebody was young, some sort of skin reaction. But here's the thing, too. Most people get antibiotics when they are sick, right? So if you get a skin rash of some kind, you often attribute it to the antibiotic, but how do you know it wasn't due to the original infection, right? Viral infections can cause skin manifestations, so maybe it was the infection. Or another very common outcome, people do tend to outgrow allergies. Just because you were allergic to something as a child does not necessarily mean you are going to be allergic to it as an adult.
That's so interesting, but it's a huge discrepancy, obviously. What are the consequences of wrongly believing you're allergic, both for the individual, but also for the system, Dr. Labos?
Well, the big problem is that if you have this label of penicillin allergy, it becomes a lot harder to treat you. When you go to your doctor for a prescription for, a pneumonia or a urinary tract infection or what have you, you can't use the standard medication. You have to start looking at the backup. So it becomes more complicated to treat somebody with a penicillin allergy. And for the system, the problem is that if you're starting to use all these backup antibiotics more commonly, that's promoting antibiotic resistance. It would be much better for everybody if we could use sort of the standard medications for the run-of-the-mill stuff and only reserve the backups for the very, very severe cases. So getting rid of these false penicillin allergies would be good, make it easier on the patients, but also help in our fight against antibiotic resistance of bacteria, because if that becomes increasingly common, it's going to become much harder to treat just every type of infection out there.
So how do we do that? How do we get rid of these false perceptions of penicillin allergy? Doctors talk about, I'm sure you'll talk about, delabeling. What is that? What does it involve?
Well, delabeling really just means taking that label off of your medical record. I mean, I sort of used the hand gesture of taking a label off. It's more often not just removing it from the electronic medical record. But it's about, the first step is really taking a detailed history, asking somebody, why are you allergic to penicillin? Now, if they had a severe reaction, meaning their throat was swelling, they stopped breathing, they had to get epinephrine, that's a severe reaction. But the vast majority of people, when you actually ask them formally, will either say, I don't know, or usually say some sort of skin reaction. And in those circumstances, those are considered low risk possible reactions. You can actually just do a direct challenge, which is you bring them into, a monitored setting of some kind. You give them a single dose of amoxicillin or some other penicillin antibiotic, and you just observe them with an EpiPen ready, of course, if they have a reaction. But more often than not, just challenging somebody with penicillin or a penicillin derivative, if they have no reaction, you can now confidently say, okay, well, you have no penicillin allergy. Stop telling people that. Make sure it's no longer written in your pharmacy record anywhere. And it could be as simple as that. For the more severe cases, you want to do sort of a more graded approach. But the very low risk cases is honestly as simple as get a penicillin tablet, amoxicillin tablet, you take it in a monitored setting, and if nothing happens to you in 30, 60, 90 minutes, then you're probably okay.
Is there a roadblock to that being done more frequently? Because that seems like a simple fix.
I think a lot of physicians probably are just not comfortable doing that sort of thing. Allergists are sadly few and far between in our healthcare system these days. So not everybody has the experience to do this. But somebody who has done this, and once you see it done, it's actually not that complicated. There were a few studies where this has been tried recently. The MUHC here in Montreal did something in their pediatric setting. And earlier this year, there was another study in an outpatient STI clinic that was being done. So because antibiotics frequently given for sexually transmitted infections, what this clinic did was they tested all their penicillin allergy patients in this way, did direct challenges, and did it in an outpatient setting. So it actually is very simple. You just have to get people used to the idea, and you sort of have to train doctors in this protocol if this isn't something that they do on a regular basis, which admittedly for many doctors it isn't.
So anyone watching thinking, I'm in this group, this is my story, what is the best advice for them then, Dr. Labos, at this point?
Speak to their doctor, and if their doctor, doesn't do antibiotic challenge testing in their office, which admittedly, again, many don't, ask for a referral to an allergist, immunologist, wherever is closer. It's not an urgent referral, but just get it done. Often a simple office visit is going to clarify this diagnosis and remove this unnecessary label from your medical record that is just making things more complicated for no reason.